Hello, my name is Roger Henderson. I'm a GP in South West Scotland, and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, you can find us on all major podcast platforms, including Spotify, Apple, and Google Podcasts. So do please follow us to receive notifications about new episodes. And if you like what you hear, do please consider leaving a review to help other listeners find us. Now, you can also follow us on Twitter at GPnotebook, and you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now, in this episode, I want to discuss an increasingly recognised occupational health condition, partly on the back of one of our listeners asking us if we could cover it. And this is hand-arm vibration syndrome, more commonly known by its acronym HAVS. This syndrome represents a significant yet preventable cause of morbidity in workers exposed to vibrating tools and machinery. And I do think that understanding its pathophysiology, clinical manifestations and strategies for prevention is essential for us as GPs. So what do I mean by hand-arm vibration syndrome? Well, it's a chronic progressive disorder of the upper limbs resulting from prolonged exposure to vibration, and it encompasses vascular, neurological and musculoskeletal injuries, often presenting to us with a combination of symptoms that may severely impact both daily functioning and quality of life. Now, historically, it was observed amongst forestry workers and miners, but it now affects people in a broad range of industries, including construction, engineering, vehicle maintenance, and utilities. Even dentists and physiotherapists using ultrasonic devices have reported it occurring. So in a nutshell, the syndrome is primarily caused by repeated and sustained use of vibrating handheld tools, and I'm thinking of things like chainsaws, grinders, jackhammers, and power drills here. And over time, the vibrational energy in these tools is transmitted through the hands and arms and causes cumulative damage to various tissues. Now, factors influencing its development include the intensity and the frequency of the vibration, the duration of daily and cumulative exposure to the vibration, ergonomics, and even genetic predispositions in some cases. Environmental conditions, particularly working in cold and damp conditions, further exacerbate the vascular symptoms associated with HAVS. And additionally, lifestyle factors such as smoking can worsen circulatory impairment, although the evidence regarding smoking as a direct risk factor does remain inconclusive at the moment. Epidemiologically, HAVS represents a serious concern. It's significantly more common in men than women by at least 10 to 1, and in 2021, the Health and Safety Executive reported over 300 new cases of HAVS in Great Britain. And it estimates that more than 2 million people in the UK are at risk from developing it, and these stats highlight a concerning increase in HAVS cases, particularly in the service sector, where over half of the new cases in 2021 were reported. Among exposed populations, it's estimated that up to half of them may develop some degree of HAVS, and despite awareness and regulatory efforts, the prevalence does remain high due to continued vibration exposure and, in some cases, underreporting or delays in diagnosis. And I think that's where we come in. Clinically, HAVS is characterized by a combination of neurological and vascular features, often accompanied by musculoskeletal manifestations. So neurologically, patients frequently report numbness, tingling and pain in the fingers and hands, and there may be reduced sensation to fine touch and temperature, along with impaired dexterity and grip strength. Now, over time, these symptoms can then become permanent and disabling. The vascular component is most striking in how it resembles Raynaud's phenomenon. So patients often experience episodes of digital blanching, particularly in response to cold exposure. And these white finger episodes can occur spontaneously or after minimal cold exposure, and recovery may be prolonged. Now, a key point here is that the vascular changes are a form of secondary Raynaud's and are a hallmark of HAVS. I mentioned musculoskeletal complications. Now, these are less emphasized but equally important because repeated trauma and microvascular compromise can lead to structural changes, including Dupuytren's contracture, carpal tunnel syndrome, cyst formation, and even osteoarthritis of the small joints in the hands and wrist. Diagnosing HAVS relies on a combination of both clinical assessment and taking a detailed occupational history. Essential diagnostic criteria include documented exposure to vibrating tools over a prolonged period, calluses on the hand, vascular symptoms such as episodic digital pallor, muscle weakness, and sensory changes that are consistent with a neuropathy. Now, importantly, other potential causes of Raynaud's, such as scleroderma, Berger's disease, and thoracic outlet syndrome, should all be excluded. If you're going to look at doing physical tests with HAVS, the ones that are typically used are the cold provocation test, Allen's test, Doppler ultrasound, and thermography. In diagnosing neurological symptoms, the light touch test, pinprick test, thermal threshold testing, vibration perception threshold, 2-point discrimination test, nerve conduction studies, EMGs, Tingel's test, and Phelan's test can all be used. Musculoskeletal symptoms are assessed by grip and pinch strength tests, X-rays, ultrasonography, or MRI. Now, during the diagnostic course, the exclusion of other comorbidities is obviously always necessary, and it should also always be the case that laboratory tests should be performed. And the ones over the years I've learned to do are inflammatory markers, a uric acid, glucose, rheumatoid factor, anti-nuclear antibodies, cryoglobulins, and serum protein electrophoresis. Also, in general, urinalysis is a good thing to do to exclude proteinuria and glycosuria. Another tip I've learned over many years is that if a male patient working with vibrating tools presents to you with what appears to be typical carpal tunnel syndrome, always consider the diagnosis of HAVS. Now, historically, the severity of HAVS was graded using what was called the Stockholm system, but this is no longer used, and a more recent two-stage classification has been introduced to separately quantify the sensorineural and vascular components. Sensorineural stages range from asymptomatic exposure to continuous numbness with loss of fine discrimination and dexterity, and the vascular stages are determined by a blanching score calculated based on the extent of the digital involvement. So looking at the management of HAVS, this is multifaceted, but the key emphasis here is on early intervention and the prevention of progression, with the most critical step, and obviously perhaps the most obvious, is the elimination or reduction of exposure to vibration. and this may involve replacing vibrating tools with safer alternatives, rotating job responsibilities, or reassigning affected workers to low-risk roles. Keeping the body warm and avoiding tobacco are also recommended as adjunctive measures to support vascular health. Now, unfortunately for all of us, pharmacological treatment has very limited efficacy, and there is no magic bullet here. Calcium channel blockers may offer modest relief from the vascular symptoms, particularly in cases where the Raynaud's-like features are prominent, but unfortunately these do not address the underlying neuropathic or musculoskeletal damage at all. The prognosis is largely dependent at the stage on which intervention occurs, and a little bit of good news here is that in very early cases, symptoms may improve or even resolve entirely once there's been cessation of exposure. Unfortunately, in more advanced stages, particularly where sensory deficits or musculoskeletal deformities are present, the damage may be permanent. And one long-term follow-up study over 22 years showed that symptoms such as finger numbness and pain often persist, especially in people who continue to have exposure to vibration. Almost as importantly, HAVS has also been shown to have a significant impact beyond the physical symptoms alone, with affected people often experiencing reduced work capacity, limitations in their everyday activities, and psychosocial consequences such as anxiety and depression. And all this underscores the need for a comprehensive, multidisciplinary approach to management and rehabilitation. And as I say, prevention remains the cornerstone here. Regulations, such as the Control of Vibration at Work regulation from 2005 in the UK, place a legal obligation on employers to assess risks, minimize exposure, and implement health surveillance. Tools must be regularly maintained, and workers must receive adequate training and personal protective equipment. Employers should also establish routine screening for early signs of HAVS, and this can enable timely intervention. So I do hope you found this quick podcast on hand-arm vibration syndrome helpful the next time you're considering the diagnosis in a patient. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Do feel free to get in touch via social media at GPnotebook, or email us support@gpnotebook.com if you've any questions, comments, or ideas for future podcasts. It's great to hear from you. You should also visit us at gpnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.